Hi everyone, it's Dr. Lisa L. Campbell. I am back with another video lecture. In this video, I'm going to focus on chapter 5, which are the diagnoses coding guidelines. I do want to remind you that this video lecture is not a substitute for reading the chapter, completing the exercises in the chapter. Also, please give yourself grace as you go through this journey. You do not learn coding overnight. The very first, most important thing that you can do for yourself is to familiarize yourself with the manual, familiarize yourself with the guidelines. All right, so by the end of this week, you should be able to identify the cooperating parties for ICD 10 CM. You should be able to explain the purpose of the guidelines. You should be able to identify the four sections of the ICD 10 CM official guidelines. Four, identify the difference between inpatient and outpatient. And then lastly, summarize the guidelines for sequencing of the diagnostic guide codes. So before we get into the chapter, I want you to know that these guidelines are available online, as in you can download a copy. And so here are the official guidelines that are effective October 1 through September 30th. So, in case you are wondering, yes, there is already a new version that is out for fiscal year 2026. But because that has not happened yet, or you're in class right now, we're going to focus on the fiscal year 2025 guidelines. All right. So I'll come back to those in a moment, but I wanted you to know that you can Google official ICD 10 CM coding and reporting guidelines and download this file. I personally print this file every year. I send it to Office, what's their name today? Office Depot, Office Max, and I have them print it and bind it for me so that I can go through it manually. Just call me old school. All right, so let's get into some of the chapter content. So these guidelines were developed by two organizations. CMS, the Centers for Medicare and Medicaid Services, and then NCHS, the National Center for Health Statistics. On an annual basis, four organizations who are known as the cooperating parties get together and approve these guidelines. Those four organizations are AHA, AHIMA, CMS, and then the NCHS. So what I just did was gave you the abbreviations for those four organizations. All right, the coding guidelines themselves are divided into four sections. Section 1 happens to be the largest portion of the guidelines. Now, when we talk about the difference between inpatient coding and outpatient coding, one thing that I want to call out for you immediately is that when you're coding outpatient, you're going to be using sections 1 and 4. When you're coding inpatient, you're going to use section 1, 2, and 3. So I think the very first thing that should pop in your head right now is like, oh, everybody uses section 4, section 1, and you are absolutely correct. So I'll say that again. Outpatient, section 1 and 4, inpatient, 1, 2, and 3. Now, let me just pop back over into these guidelines because I really want to just point out something that I just said to you, which was about the four cooperating parties. So if you look at the screen, you should see that I would say the second paragraph, it says these guidelines have been approved by the four cooperating parties. And then down towards the bottom, it tells you that these guidelines are organized into sections. So I'm going to stay over here for a little bit, which will probably cause me to skip over some of the slides that I have or that the publisher has, as I wanted to actually show you the guidelines physically. All right, so we're going to first start off with section one. Section one is the largest portion of the guidelines. Section one is divided into part A, B, and C. Part A is known as the conventions for ICD-10-CM. Part B are general coding guidelines, and then part C are the chapter specific guidelines. Oh, let's pause to recall something from chapter 4, chapter 3. The physical ICD 10 CM manual is divided into two parts, right? You have the alphabetical index, which has those four components, and then you have the tabular list. And in the tabular list, there are 22 chapters of codes. So, Section 1C of the guidelines is where you have guidelines for some, not all, of those 22 chapters. Okay. So I wanted to call that out because I think it's important just to have that understanding. Okay. So, section one, largest section divided into section A, B, and C. Then we have sections 2 and 3. Section 2 and 3 are for inpatient only. Section 2 focuses on the selection of the principal diagnoses. In inpatient speak, that's which diagnoses is listed first. So, you heard me mention that these guidelines, section 2 and 3, are for inpatient. And I think the better word to use is what's on the slide and actually reflected in the guidelines is that these guidelines are for non-outpatient settings. And here is a list of non-outpatient settings. Thought that would be important to call out. All right, so then section 3 are guidelines for reporting additional diagnoses. So when a patient is admitted to the hospital, the condition that's established after study to be chiefly responsible for occasioning the admission of the patient to the hospital is known as the principal diagnoses. Well, patients can have conditions that they come into the hospital with, or conditions that develop during the hospital stay. Those conditions can be coded as long as they meet the requirements that are specified in the guidelines. All right, then we have section 4. This is for our outpatient services. And just for clarity, these are for use when you're coding for the outpatient hospital or when you're coding for the provider. Okay. And the provider, you should know by now, is physician, nurse practitioner, physician assistant. All right, so I'm going to walk through a couple of guidelines. And before I do that, let's go back over here because I showed you where section 1A, B, and C are. But let me show you where section 2 and 3 are. And I'm going to have to just kind of, I think they start around page 100 or something like that. Maybe 101. We're going to get close to them in a second. These guidelines are also in the front of your ICD-10 CM coding manual. Definitely, if you're like me, you want to just have the guidelines by themselves. Definitely worth the investment to send them to a Office Max, Staples, somewhere they can print them and bind them together, and you can write them and all of that. So, section 2, here you see the selection of principal diagnoses. And selection of principal diagnoses is divided into letter A, B, C, D. E was deleted, long time ago, 2014. Then you have F, G, H, I, J, and K. And then you go to section 3, which talks about for reporting purposes. This is when we can capture a secondary diagnosis. It has to meet that criteria. And then since we're here, let me just show you section 4, which is divided into A through, I think it's K. I try not to memorize. Oh, more than K. Q, A through Q. All right, so those are the outpatient guidelines. And while I'm here, let me just tell you that there is an appendix, and this is for present on admission reporting guidelines. And this is for when you're coding um, inpatient. It's an indicator that attaches to the code. We'll talk about that in the coming weeks. All right. So some guidelines that we're going to call out during this lecture, with the reminder that you need to read the text chapter as well as start to look at the guidelines. But the first rule we want to call out is codes are to be reported to the highest level of specificity. ICD-10-CM can have as little as 3 characters up to 7. And based on the documentation and what is available in a particular code family, you want to code to the highest level of specificity. Next rule. This next couple of rules are related to signs and symptoms. So, codes that describe signs and symptoms can be reported when a definitive diagnosis has not been established. So, let's say the person has a cough and they have pneumonia. Um, Pneumonia is a definitive diagnosis, and so the cough wouldn't be coded. Well, let's say you didn't have anything but the cough. You could code the cough because you don't have a definitive diagnosis. Signs and symptoms that are associated with a disease should not be reported. So let's go to my pneumonia and my cough situation. If the patient has a cough and they have pneumonia, you would not code you wouldn't code cough because cough is a sign or symptom of pneumonia. Next up, signs and symptoms that are not routinely associated with the disease should be coded when present. So in your textbook, I think they have an example of a patient has an ankle fracture and they have nausea. Well, nausea is not related to a fracture, so you could code them separately. Okay. All right. Situations where multiple codes may be needed. One guideline that's called out here are situations when the patient has an acute and chronic form of a condition. If the alphabetical index provides you with a code for acute and a code for chronic, and both are documented, you can code them both, but the acute condition should be sequenced first because that's what's happening right now. All right, next up, guidelines for sequela. Sequela is something that happens after an acute phase of an illness or injury has ended. So, one example in 1989, when I was working at McDonald's, I put a fry basket on my arm and I had a burn. And then months later, a scar formed on my arm, and it was a late effect of that burn. All right, next guideline basically says that when you are reporting a single diagnosis code, you can only report that individual code once per encounter. This is important because some codes in our system do include what is known as laterality, left or right, or bilateral. But let's say that you're looking at a particular code family, it does not include that option. You cannot report the same code, the same individual code twice for that encounter because you're trying to say, oh, this is a times two situation. That's not how ICD-10-CM works. You can only report that code once per encounter. All right, so principal diagnosis. You probably heard me say this already, but I'll say it again. It is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Key thing to remember here, after study. This is the diagnosis that is going to be listed first. Now, remember how I said for the principal diagnoses, there were a couple of guidelines over there. I think it was A through, I don't remember the letter, but so here's a couple we want to call out. Number one, when you have two or more interrelated conditions, potentially meeting the definition of principal, either could be sequenced first. In the textbook, they will talk a little bit more about the word interrelated. Next, when two or more comparative diagnoses are documented, either can be sequenced according to the circumstances of the admission. Here, we're talking about really getting into the weeds of inpatient coding, and we're not going to get into that at this point. All right, let me make sure I didn't skip something. Okay, next. Sequence as the principal diagnoses, the condition which after study occasion the admission to the hospital. So this one, I think, when you look at it on the screen, is a little confusing. So I want to take you into the guidelines to what they're actually calling out. And what they're calling out are situations when the original treatment plan has not been carried out. So let's say the patient comes in, they are scheduled for a hip replacement surgery, right? So they're admitted to the hospital, ready to get that surgery done, and they all of a sudden get congestive heart failure, and the surgery is canceled. According to the guidelines, even though the original treatment plan was not carried out, that hip fracture should be the principal diagnosis, and then you would list that congestive heart failure. There is also a Z diagnosis code that we would use as well that says procedure not done or something like that. Okay, I wanted to call that out because I think the way it's listed here might be a little confusing. All right. So the next guideline is when the admission is for treatment of a complication. The complication is sequenced as the principal. So a perfect example of that is, let's say a patient had outpatient surgery. Outpatient, supposed to be going home, but let's say that that patient had surgery, had some type of complication, requires that person to be admitted. That complication is going to be the principal. And the last guideline here is about uncertain conditions. So let me go over to the guidelines. So here I am in section 2, principal diagnoses of the guidelines, letter H, which basically tells us in an inpatient setting, you can code uncertain diagnoses. Okay. The doctor says probable, I think it is, it could be, it might be, it looks like, you can code it. But when it comes to outpatient, and I'm going to flip over to those guidelines, here, letter H, do not code uncertain diagnoses. So you see the difference between inpatient versus outpatient. Inpatient, you can code uncertain diagnoses. Outpatient, you cannot. All right, couple more things here and we'll be wrapping up. So I already talked about section 3 of the guidelines relate to secondary diagnoses or other conditions. These are conditions that coexist at the time of admission. Those are known as comorbidities or things that develop subsequently, complication. All right. So in the actual guidelines, and I'll pan back over here just for you to see it At the very top of the introduction to section 3, it tells you that for reporting purposes, the definition of other diagnoses is interpreted as additional clinically significant conditions that affect patient care in terms of requiring, so it needs to meet one of those 5 items. All right. Outpatient guidelines. So, in an outpatient setting, we use the word first listed instead of principal. When we are coding outpatient, I've already mentioned we do not code uncertain diagnoses. And then the first listed diagnosis is that condition that is responsible for that encounter. All right. In the outpatient setting, if the patient has chronic conditions, they can be coded and reported as long as they're being treated. And any other secondary diagnoses that are impacting the outpatient encounter should be coded as well. And then another couple of guidelines to consider. Number one is a situation where a patient is coming in for a diagnostic service only or a therapeutic service only. You are going to sequence first the reason for that diagnostic or therapeutic service. Diagnostic means that they're trying to find out a diagnosis. Therapeutic, they know what the diagnosis is, they're treating. Then for ambulatory surgery, you are going to code the reason first for the surgery. And when you think about these guidelines, they absolutely make sense. All right, so we have come back to where we started. Highly recommend you spend some time this week looking at those guidelines, keeping in mind you're not going to learn all of those guidelines overnight. There are 120 pages in this guideline file, and so you can definitely see that this is a journey and not a sprint. All right, thank you so much.